Good evening, everyone. I would like to thank organizers for giving me this opportunities. I am Dr. Prabhat Bhargav from Tata Memorial Hospital, Associate Professor and Consultant in Department of Medical Oncology. I would be speaking about implications of sidedness and molecular diagnosis in management of colorectal cancers. Am I audible?
Yes, sir, you are audible. Slides are visible. You can go ahead.
So, colorectal cancer accounts for approx 10% of all the annually diagnosed cancers and cancer-related death worldwide. It is second most common cancer diagnosed in women and third most common in the men. In women, the incidence and mortality is approximately 25% lower than men. And with continuing progress in developing countries, the incidence of colorectal cancer worldwide is predicted to increase to 2.5 million new cases in 2035. So is colon cancer a one disease? No, you can stratify it into multiple types based on the molecular markers and the anatomic locations versus age based on the flora. This is what I have to give you a clarification on. So some idea we can get based on the consensus molecular subtyping of colorectal cancer, which also divides colorectal cancer into CMS 1, 2, 3, 4 based on various parameters. So is right-sided really a different entity compared to the left side? So right-sided, as we know, comes from the hindgut. We defined it from the cecum to two-thirds of the transverse colon, last one-third of the transverse colon, and up to the rectum is considered into the hindgut. The right-sided colon cancers are more common in women. They are more of mucinous variant. They spread from the peritoneum. The hindgut variant are more common in men, and they have a better prognosis. I will justify you in subsequent slides how. Why is right-sidedness different? So a SWOG 80405 study was conducted when we were not aware of the sidedness, and based on just the molecular marker of KRAS, patients were divided. If they were wild type, they were given bevacizumab versus cetuximab, and chemo background remained as FOLFIRI or FOLFOX. And you can see they were astonished to find there was no difference in the survival of bevacizumab arm or cetuximab arm. So why did it happen? Then on further analysis, subgroup analysis, which were later on published in 2000, mutation on the right side, and right-sided has an overall survival of around 19 months compared to the left-sided tumors when they were treated with similar chemotherapy backbone, compared to the overall survival in the left side, which is around 33 months. On further subgrouping also, they found that there was more BRAF variant and more MSI variant in this right-sided tumors. Similarly, other studies also show that there Fire 3 and Crystal also show that there is difference in the overall survival of the if whenever the patients are treated with same backbone, still they do differently. When they are of right-sided, they have worse survival compared to the left-sided. Now let us come to the molecular markers. So these are the common molecular markers till now which we do or are upcoming in the therapy. KRAS, which is found in around 40 to 50% of the patients, NRAS, which is found in around 4 to 5%, BRAF mutation in around 8 to 10% of colorectal cancers, HER2 in around 5% of the patients, and some case report up to 26%, and NTRK fusion in 1%, and MSI high has now come into picture even in the first line setting. Let's before entering what are this mutation, why are this important? Let's come to cell surface and enter the cell. So on cell surface there are receptors EGFR, which why now that cetuximab and panitumab can inhibit these receptors. Or once we enter the cells, there is a RAS pathway where RAS BRAF come downstream, and if RAS or RAF is mutated, even if you inhibit EGFR, the cell will continue to proliferate because the downstream is mutated and cell will continue progress and oncogenesis will happen. So just inhibiting anti-EGFR will not help us to stop the proliferation of the cell. That is why we need to know which tumors are RAS mutated or BRAF mutated, so that those patients are not suitable for anti-EGFR therapy. And in those cases, we can use anti-VEGF related therapies. So in KRAS mutated, when there is benefit of adding anti-EGFR therapies, the same was described in all the studies that have tabulated. Prime, Opus, and Crystal all showed that there was overall survival, PFS and overall survival benefit when we added anti-EGFR based therapies like panitumumab, all cetuximab on first-line therapy of FOLFOX, all FOLFIRI. Let's come to BRAF. So PETEC trial, they found out that there was something, even after giving or excluding RAS wild type, there was something which had described the difference. There was attackingly difference in the overall survival. On further analysis, they found out that there was something called as BRAF mutation also. So those who have BRAF mutation, they did worse compared. Their overall survival was inferior compared to those who were BRAF wild type. Further, a trial also shows that this BRAF mutated should be treated with FOLFOXIRI BEV, that is triplet therapy in first line setting along with BEV in first. So we have to go aggressive in BRAF mutated tumors from first line itself, as rationale I have already discussed before. Further, just inhibiting BRAF did not help. So why? Because they overcame via the MEK pathway. So another inhibitor of BRAF of the pathway was adding vemurafenib to the and EGFR path. Adding vemurafenib, so Beacon trial had come, which showed that just MEK inhibitor combining with BRAF inhibitor would do better than just combine the BRAF inhibitors. So phase 3 Beacon has now shown to us the survivals. Okay, the doublet did. Sorry, this is not being displayed. The slide is not being displayed. The doublet had an overall survival of 9 months compared to the triplet also. So adding third drug did not add much benefit in this Beacon. The 3 drugs, only encorafenib and cetuximab, that is BRAF inhibitor and cetuximab anti-EGFR inhibitor, is equivalent to adding a third drug MEK inhibitor to this combination. MSI high. So what is MSI? So we know body requires 4 protein for DNA reparation, that is MSH1, MSH2, MLH1, and PMS2. If these are deficit, the mismatch in the DNA is not repaired, and either the cell will not proliferate, or if it proliferates further, it would be a mutated cell. That is why if there are MSI is mutated, carcinogenesis, if it happens, it will be a mutated cell, and these cells will keep on mutation further, and new antigens will keep on developing in the cells. These are more common in the right side. Why? One of the hypothesis is because of the gut enterobacteria in the gut. What is the significance? So significance of MSI starts in the adjuvant therapy itself. The adjuvant therapy, we know that those who are MSI high in stage 2, they hardly require any adjuvant therapy, because they hardly spread to node. Even if you don't treat with chemotherapy, there is a resistance to go to node. Once they go to node, they do worse compared to the non-MSI high. So there was a need for those in metastatic setting. So this was fulfilled by this pembrolizumab study, Keynote 177, which in first line, those who were MSI high were randomized to pembrolizumab arm, where 153 patients, and the investigator choice chemotherapy arm, 154 patients, with a primary endpoint of PFS. And till now, OS analysis is pending, but the PFS was starkly increased from 8.2 months in the chemotherapy arm to 16.5 months in the immunotherapy arm. And the overall response rate was better in the pembrolizumab arm of 43.8% compared to chemotherapy arm of 33.1%. And CR rate and other parameters were better in the pembrolizumab arm, that is immunotherapy arm, compared to chemotherapy arm. Similarly, similar findings are seen that response rate with nivolumab alone were around 31%, and the same was when the nivolumab and ipilimumab were combined, the response rate had increased to 51%. The overall survival, I'm sorry, the graphs, slides are not seen properly. Overall survival is still pending. The PFS is around 9 months of the nivolumab arm alone, and it is around at 12 months, 77% patient had progression free in the combination arm. HER2 overexpression in colorectal cancer. So we know HER2 is an important biomarker, especially in the breast cancer, where trastuzumab and other HER2 targeted therapy have changed. And studies have shown that there was HER2 over amplification in colon cancer also. When to define as HER2 amplification is when there are more than 50% of the cells are expressing HER2 expression, then it is given as HER2 3 plus, not compare what in how it is defined in the breast cancer. The definition is different in colon cancer, that one needs to keep in mind. And these patients were treated in this way, single arm study. In second line, and those who had finished had received prior for 5 fluorouracil, irinotecan, oxaliplatin, cetuximab, or panitumab, or a prior bevacizumab, alifbercept, or regorafenib, were given anti-HER2 targeted therapy, that is a combination of trastuzumab and lapatinib. This patient showed an overall response rate. This study was planned for primary endpoint of overall response rate. The response rate in the second and third line patients were around 30%, which is astonishing. And they had maintained a stable disease for more than 4 months in 30%. I'm saying about in third line setting that we are talking about. And stable disease for less than 4 months were only in 15 patients, and progressive disease in 25%. Similarly, another anti-HER2 targeted therapy study was My Pathway study, where they combined trastuzumab with pertuzumab. Over here also, it was planned for seeing the response rate, and they could see that the response rate were better compared to what they had planned the study for. So, and we further know that HER2 is an resistance marker for anti-EGFR antibody, and it defines patients who are candidates for HER2 targeted therapy. Based on this, further studies of trastuzumab deruxtecan is also ongoing, and so and so forth. Further HER2 therapy, we should start testing patients for HER2 amplification in our colorectal cancer patients. Thank you.
Thank you, sir. And now I'd like to invite SN Singh sir to invite Amit sir, who is a consultant at Patna.